I'm an academic surgeon, which means, there you go, that I spend 2 days a week doing clinical work, so 40% of my time. I have a contract which is a team annualised job plan, so 40% of my time I do 40% of what my 100% colleagues do, lists and clinics and multidisciplinary team meetings and things, and then all the rest of the time, which is the other so-called 60%, I do academic work. And the academic work mainly involves directing the MRC hub for trials methodology research, which means that we work out better ways of doing studies and doing trials. And then I happen to also direct this Royal College of Surgeons trial centre, so I get the immediate opportunity, once we've developed the new methods, to put them straight into new trials that we're running from the trial centre, which is a great opportunity because it can make them both work better, and they both immediately deliver the outputs that we're meant to do, as well as some education and training and capacity building and that sort of thing. And the Bluebell study is one of those exact projects. It's come out of the methods from the methodology hub, put straight into a surgical trials proposal. So what I'm going to do is tell you a story. I can't resist telling this story. And I've told this story lots of times, but this is the first public occasion I've told the Bluebell story. And then I'll tell you about the design of the Bluebell study, which has not started yet. So it's your opportunity then to tell us how to do it better, and we'd love to hear your views. So there's plenty of time for questions afterwards. So here's the story. About 3 years ago, we had a competition that we ran in Bristol, and we ran it with all our registrars in surgery in the 7 deanery, which is the deanery responsible for training in the southwest. And we advertised to them the opportunity to submit their ideas for a randomised trial. It had to be a randomised trial. And we gave them the instructions for how to do this. They had to write an abstract with a title, a bit of background, the actual purpose of the study, the primary outcome, all the usual stuff, sample size calculation and things like that. We had 11 submissions. And then I created a little committee of trialists, surgeons, and also methodologists from Bristol and from the peninsula in the region. And we sat round, and I can remember it so clearly in my office, and we looked at these 11 applications. And 2 of them were really good. And those 2, one of them was looking at the role of antibiotic-coated sutures to prevent surgical site infection. So it was a randomised trial of patients either having an antibiotic-coated suture or a normal suture. And that one we decided would win a prize, and we gave it £300. And on the basis of that, we wrote a grant application, which was shortlisted for the main funding, but we've got it on hold there because we're waiting for an international trial to finish before we put the main trial in. And the other idea came from a woman, a female trainee, of which we have lots in the southwest, and her name's Jo Walters, and I think she did some work based here in York. And it's great to be here in York, by the way. I meant to say that. Forgot. Sorry. It's lovely. I really like York. And Jo had done a systematic review with the centre here, and that systematic review was looking at the role of wound dressings. And she submitted the idea for this trial of a trial comparing dressings with no dressings. And she wrote it beautifully, and our committee looked at it and thought, great idea for a trial, we'll give her the second prize. So 2 prizes were awarded. The first one we worked up into this grant application, and this other idea of Jo's, we thought, well, great idea, impossible to do. There's no way anyone would do that study. And I thought about it. I thought every time I do an operation, there's no way I would not put a dressing on the wound. Thought, oh, it'll take loads of feasibility work, definitely not going there. Kind of forgot about it. You know, she got the 300 quid, and that was that, really. And then, this is the interesting bit of the story, then I met Bluebell. And the great thing about Bluebell is there's so many lovely pictures. And what happened was, I was on call, and it was August bank holiday weekend, Saturday night, and I was in the intensive care unit dealing with some esophagectomy problem. I'm an esophageal surgeon. We spend a lot of time in the intensive care unit dealing with esophagectomy problems. And I overheard a conversation. I'm a bit nosy, I think. I overheard a conversation by one of our vascular surgeons called Marcus Brooks, who you probably know, one of the vascular surgeons here. And he was on the phone to paediatric surgeons, and he was saying, I don't think we can do anything else. No, I'm sorry, that I just don't think we can do it. Isn't that awful? I think that's got to be the end of it. Put the phone down. So I said, oh, Marcus, what was all that about? And he said, oh, it's really sad. There's this 11-year-old girl who has had a thrombotic episode. She had spun off a thrombus to her gut. She had a family history of clotting disorder, and the blood supply to her gut had been cut off. He'd operated on her 3 days ago to try and extract the thrombus from her superior mesenteric artery because she had a dead foregut or something. And all had been well for 2 days, and she'd really gone off and was really deteriorating rapidly. And he'd said to the paediatric surgeons, I'm sorry, there's just nothing more we can do because it's, the gut's dead. And I think it involved her celiac axis partly as well. So it was part of her stomach, part of her liver. It was a really difficult situation. And because I'm an upper GI surgeon, I said, well, surely we could have another look. I'll go for it. He'd also was really tired. He'd been up all night, and you know what it's like. He just thought there was nothing he could do. And I said, I'll go over there and see maybe there's something we can do. So I found my way to the operating theatre in the kids' hospital. I'd never been there before. And it was 11 o'clock by the time we did all this on a Saturday evening, bank holiday, August. And we opened her up and chopped out some more dead gut, blah, blah, blah. It was actually very straightforward, and I just sort of stood there and encouraged this paediatric surgeon. Brought out a really proximal stoma with her duodenum, and everything looked a bit dusky, but it was okay. And then he finished the operation, and I de-scrubbed and just stood there chatting, like you do, end of the evening. And at the end of the operation, he finished it, closed the wound, closed the skin. That was that. And I said, well, where's the dressing? And he said, well, we never use dressings. Paediatric surgeons don't use dressings. So 11 o'clock on that Saturday evening, I went, ooh, maybe we can do that study, which I thought would be impossible. So I said, you sure that the paediatric, I couldn't believe it. Our hospital's actually adjoined. There's the kids' hospital, same building as the adult hospital. I've only worked there for 25 years. And I had no idea that paediatric surgeons never use dressings. He'd worked around the country. No, never used dressings. Isn't that interesting? So I thought, well, maybe that study's possible. Now, that little girl's name was Bluebell, a ridiculous name. So what I learned, who would call their daughter Bluebell? Well, what I learned from that was, A, don't call your daughter Bluebell. We have got her permission, her written permission to do all this, and so it's perfectly okay. She knows the study's called after her. I also learned that maybe it would be possible because in their eyes it was abnormal to actually stick a dressing on. So following that, I'd sort of thought, well, it's possible. Didn't really then think anything more of it. And a few days later, or in fact a few weeks later, the HTA came out with a commission call asking for feasibility work to look at whether it would be possible to do a trial of dressings versus no dressings. So I went, come on, guys, and pulled the team together and said, we're calling this the Bluebell study. And they went, no, we're not, Jane. No way are we having a study called that. I said, sorry, we're calling it the Bluebell study. And eventually they came along with me, but, we've now got one called Violet. So this is the evidence. So there's a systematic review. It's the one that Jo Walters was her name. She's first author on the BGS paper and in the Cochrane review as well. This is the evidence of dressings for surgery, elective surgery, to prevent wound infection. It was nicely done, systematic review, all done properly. And at the end of the day, there were 16 randomized trials. There are 16 randomized trials, and they were all poor quality, all at high risk, 3 at high risk of bias, and the other 13 at unclear risk of bias. And what I teach my registrars when I train them in academic things for them to pass their exam is if the methods are poor, there ain't any point in reading the results. And I'm afraid that's true of most of these studies. They're so badly designed that the results, all they reflect is the biases of the authors rather than what the actual data show. Now, in amongst those trials, there were a few where they'd use no dressings, but there's no decent studies. So the purpose, no significant, and the few they did in meta-analysis of the bad studies showed no difference between them anyway. So the purpose of our Bluebell study is actually to find out if it's possible to do a main randomized trial. So it is a pilot trial, pilot study, which won't produce actual results. The whole purpose of it is to design and to make sure, or see if we can run a main multi-center trial. And that's quite a big investment. And when you talk to the NIHR, they say that when they fund these sort of studies, standalone randomized studies, the reason why they're standalone is because they expect them never to go into a main trial. They think that they'll fail, and that's why they fund them as standalone pieces of work. So that's a challenge to us for a start. So the purpose of this study is to design the main trial. Now I'll tell you about the trial. So it's got 2 parts to Bluebell. The first part is preliminary work, necessary preliminary work to design a randomized pilot, and that's a little randomized trial, the pilot study, and together those two things will inform the main trial design, which we will have to apply for separate funding to do. Does that make sense? So there are three interesting pieces of work that we're going to do in phase A. And I really like this picture. This is the kind of touchy-feely bit, if you like. So this phase A part of work is going to involve basically interviewing and non-participant observation of people that do use dressings and people that don't use dressings. So the researchers based in Bristol and in Birmingham, we're going to work between the two sites, are going to use qualitative methods to observe paediatric surgeons and interview paediatric surgeons as to why they don't ever use dressings and why they think that matters or doesn't matter. And then the same methods in adult elective surgery, abdominal surgery, and in caesarean section and obstetric surgery to find out why surgeons and nurses and everyone else thinks that dressings are necessary and what they might think about doing a trial without dressings. So we're going to get lots of information, we're going to understand behaviours, we're going to work out what's acceptable to people and think about how to use all that to design our study with an arm with no dressing. And that will yield all sorts of stuff, some of which we already know, because I've been going around talking to people about this, and maybe we can talk about that afterwards, about what people think about dressings and no dressings and what that all means. So that'll be interesting. The next thing we're going to do in that preliminary work is actually come to some definitions about what no dressing really means. Because does it mean glue on the wound? Does it mean staples and clips? Does it mean some spray? You know, all the stuff you can use. What actually does it mean to have no dressing? Somebody suggested to me that maybe the definition of no dressing is something that doesn't need to be removed. We don't know. There is no accepted definition, and we need to have definitions, working definitions of it. We also need to have definitions of what a simple dressing might be or a complex advanced dressing. Because within those three categories, there's any number of different things we can use. We're not going to restrict the main study to one dressing versus another. We're going to have agreed categories with boundaries, and we'll say all those ones there are classified as complex advanced dressings, and all those ones here are classified as simple dressings, and this is what we really mean by no dressing. And you can pick from those three categories. But there'll be some things that are actually out with those, that will say that one, that particular sort of dressing doesn't actually fit within the three categories, so you can't use that in the main trial. But we want to be as inclusive as possible because the main trial will be pragmatic, very pragmatic. So I think this will also be an interesting piece of work, get the costs on all the dressings and all that sort of thing. And then the third thing, and this will be hard work in the preliminary thing, is just really to sort out, I don't think we'll be able to do this, but we'll have a good go at trying to sort out how to measure SSI. I'm sure you lot know a lot more about this than I do. But the two methods that are commonly used for measuring surgical site infection, used in surveillance studies and in research, the asepsis questionnaire and the CDC SSIS measures, do have their problems. Neither of them have really been truly validated and checked for reliability. Neither of them have had true patient-centered type of questions in them, and both of them need a bit of a sort-out. There needs to be head-to-head comparisons. They need to have patients' views in them. So we're going to do quite a lot of hard work trying to sort out a measure so that by the time we get to the main trial, we have a validated and reliable patient-reported measure and also observer-assessed measure of SSI that can be used in the main trial that is cheap and efficient and accurate. Because otherwise, if the main trial has thousands of patients in and they all need to go and see a surgical registrar or a trained research nurse, it could cost a fortune. We don't want that. So this is a hard piece of work, but fairly interesting. And then, once we've done phase A and done all that preliminary stuff, we are going to design an external randomized pilot, which, if it doesn't have 3 arms in, I will totally lose interest, because the only thing that really interests me about this is whether we can do the no dressing thing. But it may be 2 arms. We may say it's simple versus no, or it may say it's complex versus simple. I hope not. But we're thinking we'll have a 3-group randomized external pilot, just to see how we can recruit, to see the numbers that will agree to be randomized, to see if we can measure the SSIs, see if people adhere to it, because that's the big thing, isn't it? So I did just a simple laparoscopy on a patient a few months ago, and I told everyone the Bluebell story when I was in theatre, and they all listened and laughed and sounded saying it was fascinated. I said, okay, we'll try it then. Laparoscopy, 3 1-centimetre incisions, no dressing. Let's just leave the dressing off. Everyone went, yeah, that's fine, yeah, that's fine. And that was that. Just left the dressing off, and I got a text message from the registrar the next day, patient fine, dressing on. And that's what's going to happen, isn't it? We might randomise patients to no dressing, but everyone else is, before we know it, it's going to slap something on it. So one of the big things in the Bluebell randomised phase is to look at adherence to the intervention and to actually educate everybody, it's going to be hard work, to leave the dressing off and not to worry about it. So that's all going to be fun as well. So what's the time? Finished, I think. What's it going to look like? What's the main trial going to look like? Well, if we can prove that it's acceptable and possible to randomise people to not having a dressing, and we really know what that means, and we can measure SSI cheaply and accurately, this main trial we think will be a non-inferiority design, include thousands of patients, and it will probably address, I want it to be just simple versus no dressing, probably address that no dressing is cheaper or more cost-effective, I think the word is, but no worse than a simple dressing. And that will really involve lots of centres and people, and we would love to do that. We'll have to see. And this is a bad photo that we took of the team recently, but clearly this includes this piece of work. It reflects a multidisciplinary team. We have qualitative researchers, we have nurses, we have surgeons, surgical trainees, methodologists, who else is there? All sorts of people, patient representatives. And we do actually have a lot of fun doing all this, and I'm very pleased to take some questions. Oh yes, if you want to design the Bluebell logo, there's a competition, There's a competition, another competition out at the moment, and we want a Bluebell logo with some sort of, the image will be something to do with wounds, something to do with Bluebell, the flower, and the prize is an iPad, so it's worth going for. So you can get the full details if you email me or the study team. Thank you.
Thank you very much, Jane. Have we got any questions? Yes, Michelle?
I think the design is fantastic, and incorporating and starting with qualitative work is brilliant, because I think that will show a number of things. One, which is the theory behind what a dressing is for, which is not necessarily infection prevention. It could be. I mean, one of the studies I was involved in looked at opsite versus, so basically simple versus complex dressing for surgical wounds quite a long time ago.
Yep.
And it showed no difference in terms of healing. It showed no difference in terms of pain score until you exposed the wound, and then there was a statistically significant difference in pain scores.
Right.
With an exposed wound versus a covered wound.
Yeah.
And so there are other things that maybe need to be taken into account. So
Yeah.
I wondered, in your qualitative phase, whether you're talking to patients about whether they want a dressing or not.
Oh, definitely. So the qualitative phase is with staff in the kids' hospital, not children, but just the staff. But in the adult setting, it's patients and staff. And pain is in there. But the other thing is exudate and ooze, because that's what some people think dressings are for in the early stage. And I said that night in the children's hospital when I was going, what, you don't use dressings like this? I then immediately said to the surgeon, but what if it's oozing? I immediately said, and why don't you use dressings? And he said, oh, we just put a bit of blue gauze on it, just let it sit on the wound immediately in the recovery room. And then, when it drops off, or when you have a bath, it comes off. So probably within our definition of no dressing, you'll be allowed to just shove, not tape on, but just put a bit of blue gauze on.
And maybe take into account the pain at dressing changes and removal then?
And he also said the reason why children don't like dressings is because of the pain on removal. So, there's all sorts of things in there, and that's what all the qualitative stuff is going to look at.
And you might, in terms of the outcomes, try and measure tactile and punctate allodynia, because that's actually, it's not just patient report of pain, it's actually whether pain is caused at the point of pressure or a point of touch.
We will, thank you.